For those who don't know me, my name is Rafal Kopanchik. I'm coming from Columbus in Ohio, and I'm one of the co-chairs for the ProEd committee. And I would like to thank the Thomas Jefferson Group for getting this figured out this year and getting so many great speakers, and that will continue throughout the day today. A couple of housekeeping items. Make sure you guys review all of the sessions to get the CMEs and all that jazz. And then the on-demand videos will be available starting in December. So that's where the on-demand content will be out. So if some of your colleagues weren't able to join, just let them know they will still have an ability to pay for it and watch it at a later time. But now, without further ado, let me introduce to you our second to last session that will deal with chronic pain and metabolism. So we are grateful to be joined today by Drs. Andrew Mendelson and John Wenzel. Dr. Andrew Mendelson is a double board certified anesthesiologist specializing in chronic pain management with clinical interests in cancer pain, medicine, and neuromodulation. He emphasizes a multidisciplinary, individualized approach and is skilled in minimally invasive spinal procedures and advanced therapies. Dr. Mendelson earned his medical degree from Lake Erie College of Osteopathic Medicine, completed his anesthesiology residency at Thomas Jefferson University Hospital, and pursued a pain medicine fellowship at the Tri-Institutional Pain Fellowship in New York City. Before joining MUSC, he was an assistant professor and associate program director of the Pain Medicine Fellowship at the University of Virginia. Today, he will be speaking on advances in pain management. Please join me in welcoming Dr. Mendelson.
Good morning, everyone. Thanks for having me. I'm going to be discussing some advances in pain medicine and things that I've been able to add to my practice over the last couple years. I have no disclosures or financial interests to disclose. We're going to first review some of the epidemiology and pathophysiology of chronic pain, as well as low back pain in the United States. Talk about some of the diagnostic workup and traditional treatments for low back pain, and then introduce some new emerging and innovative technologies for treatment. So what is pain? Per the IASP, pain is defined as an unpleasant sensory and emotional experience associated with the actual or potential issue or potential tissue damage. There's acute versus chronic pain. Acute pain typically has a clearly identifiable cause, such as post-surgery, whereas chronic pain is more complex. Sometimes the cause is unknown, and it persists for greater than 3 months. Then you have nociceptive versus neuropathic versus nociplastic. Nociceptive arises from an actual or threatened tissue damage, whereas neuropathic is caused by nerve damage or dysfunction. And finally, nociplastic pain results from altered nociception in the absence of any tissue damage or nerve injury. And this is often associated with central sensitization. So chronic pain, again, it's defined as pain persisting more than 3 months. It interferes with activities of daily living, work, social relationships, may be due to an underlying injury, or it may be even more complex and the underlying cause is unknown. An estimated 50 million people in the United States suffer from chronic pain, about 1 in 5. And there are a lot of challenges in managing these patients, as pain is very subjective in nature and responses can be very variable to treatments. Something that surprised me, it is one of the most common causes with an office visit in the U.S. with an annual prevalence of 10 to 30%. It's overall the 5th most common reason to visit a doctor in the United States, and it's the #1 cause of disability and retirement worldwide. It's highest among people who are involved with manual labor jobs, low job satisfaction, and poor workplace compliance. For someone who's out for 6 months due to pain, they have a 50% return to work. If patients miss 1 year of work due to pain, only 25% are expected to return. And after 2 years, these people unfortunately do not return to work. In the United States, it costs about $90 billion per year for treatment of low back pain alone. So differential diagnosis, I kind of divide this up into 3 categories. You have the mechanical low back pain, and this is going to be the degenerative disc disease, spinal stenosis, fractures. You have non-mechanical spine disease, and this is related to cancers, infections, inflammatory rheumatoid arthritis. And then it can be visceral disease, which more of a referred pain, So it can be prostatitis, pyelonephritis, or GI pancreatitis. So we'll start with a little bit of a case. There's a 65-year-old male with a past medical history of hypertension, had a 10-week history of low back pain, began without any inciting event. It does not radiate to his lower extremities, denies any lower extremity numbness, tingling, or bowel bladder incontinence. So this is something I see probably 4 or 5 times a day in my office, and typically start with physical exam. So want to inspect, palpate, neurologic exam, motor strength testing, sensory exam, look at reflexes, special tests, and then examine the gait. Want to always rule out the red flag exam findings, so fever, history of IVDU, any bowel bladder incontinence, major motor weakness, can be a sign of nerve root compression, histories of cancer. Point tenderness can be related to vertebral compression fracture, or if they have an upper motor neuron sign on exam. So typically I see 2 different types of low back pain. It's axial versus radicular. Axial, it's non-radiating, kind of in the middle of the low back. I'm thinking of lumbar facet syndrome, sacroiliitis, degenerative disc disease. And then for radicular pain, I'm thinking more of like a herniated nucleus pulposus or a lumbar radiculopathy. Could be related to spinal stenosis or failed back syndrome, someone who's had back surgery, but their neuropathic pain is still there. So different differentials, again, just to get a little bit more into it. Degenerative disc disease, this is also known as discogenic pain, internal disc disruption, or painful degenerative disc disease. This is typically an aching pain in the axial back. Worsens typically with intradiscal, with activities that increase intradiscal pressure. So I always ask about long car rides, sitting for long periods of time, standing, coughing, sneezing, and this can definitely exacerbate degenerative disc disease or discogenic pain. Sacroiliitis, also very common. This can typically be in the low back, but can also refer. Typically, it does not go below the knees if there's any referral of the pain to the thighs or the hamstring areas. The SI joint is the largest axial joint in the body. Low back pain, it may present as 10 to 25% of patients. And then they have special SI joint maneuvers which we need to do in order to proceed with any or confirm the diagnosis. The special tests all have a low sensitivity, and you need multiple of them to get a high specificity with them. So imaging for evaluation of low back pain. Typically start with x-rays, get AP laterals, look for any type of facet arthropathy, fracture, spondylolisthesis, scoliosis. What I really want ideally is an MRI, but insurance makes us wait around 6 weeks of conservative treatment in order to proceed with any type of advanced imaging. Typically, my patients sometimes do not like going to physical therapy, so I use the American Academy of Orthopedic Surgery spine conditioning guide as a home exercise program. But an MRI is what I really want, and that'll give me more specific information in regards to the degenerative disc disease, if there's any type of herniations, stenosis, whether foraminal or spinal, or any type of compression fractures, and tell me the acuity of the compression fracture, whereas an x-ray can't do that. So traditionally, what have I always done? Treatment options, starting with medication management, anti-inflammatories, neuropathic medications, the gabapentinoids for radicular pain, muscle relaxants, the physical therapies, acupuncture, chiropractic care, TENS units, and then I move on to the interventional approaches. So the epidural steroid injections, the facet injections, SI joint injections, some neuromodulation, and then new treatments that I've now added to my practice over the last couple of years are suzetrigine, intercept procedure, or reactivate procedure, which we'll go into shortly. So just review of the common or the previous approaches we would always take for this. For epidural steroid injections, it's indicated for radiculopathy or stenosis with neurogenic claudication. We can do up to 4 epidurals a year if the patients are getting 50% pain relief for 3 months. It's good for short-term relief, but there's limited data for long-term efficacy. You have medial branch blocks and radiofrequency ablations, and this is indicated for facet-mediated pain. So this is an axial pain, non-radicular. They shouldn't have any weakness or motor symptoms on exam. We have to do medial branch blocks, and these are test blocks at the levels. And we just inject a half a cc of local anesthetic, and we're looking for 80% relief for the duration of the local anesthetic. We have to do this twice for insurance reasons, but if successful, we can proceed with a radiofrequency ablation, which uses radiofrequency energy, which generates heat, which denervates the nerve. This procedure typically lasts between 6 and 12 months and can be repeated if the pain were to return. There are different types of radiofrequency ablation. There's a conventional radiofrequency ablation, typically done in the they're all typically done in the office, but different costs associated with them. This just creates more of a teardrop lesion, whereas a cooled radiofrequency ablation still gets to the same temperature, but it prevents the tissue around the needle from charring, so it creates more of a spherical and a larger lesion. And then some of the newer technology are protruding electrodes. There are a couple of them. They have a trident probe, or kind of this one down here, which I don't think anyone can see. The one on the bottom left is the protruding, and that creates a larger lesion as well, and less cost associated than the cooled radiofrequency ablation. SI joint injections, again, you need 3 positive tests, and these are done into the joint themselves. There's no data showing intra-articular versus peri-articular are more beneficial to the patient. And again, we're able to do 3 to 4 of these a year, depending on pain relief. Previously, a couple years ago, we were able to do ablations of the lateral branches, but this is no longer approved per Medicare guidelines. About 5 years ago, I added peripheral nerve stimulation to my practice. And there's 2 different types of peripheral nerve stimulators. You have 60-day versus permanent peripheral nerve stimulators. And for low back pain, we're targeting the medial branch nerve of the dorsal rami. And this can be placed under either fluoroscopic or ultrasound guidance. This needs to, unfortunately, be done in an ASC or an HOPD. So that does limit this. Luckily, one of my offices is an HOPD, so we're able to do it in the office, and the procedure itself takes 5 to 10 minutes or so. Back in 2023, they looked at treatment of chronic low back pain with peripheral nerve stimulators. Gilmore and the team looked at 74 patients with the temporary 60-day peripheral nerve stimulators. Patients were using it between 6 and 12 hours, and almost 75% of patients were identified as responders to the peripheral nerve stimulators, with an average reduction of 67%. Even after the stimulators were removed at 60 days, patients reported sustained improvement up until 14 months. And this kind of just shows the data in kind of a graph view. So 70% reduction while the stimulator was in, but even at 14 months, these patients had over 50% improvement in pain intensity, disability, pain interference, and then the BPI decreased significantly, again, while it was in, and then it was sustained until 14 months. Spinal cord stimulation, traditionally it was only on label for post-laminectomy or failed back syndrome, or complex regional pain syndrome. Over the last couple of years, they've added new indications, including diabetic neuropathy and non-surgical back pain. It's a 2-step procedure where we do a trial in the office where we just percutaneously place the leads. The patients, I tell them they get to test drive it for about 5 to 7 days. If they receive more than 50% pain relief, we're able to implant it, where everything comes out, but we place it and everything goes underneath the skin. There are multiple different companies with multiple different mechanisms of actions, but some of the theoretical mechanisms of action are the gate control theory, so activating the A-beta fibers, efferents, blocks the pain signals from being transmitted. The stimulators also block transmission in the spinal thalamic tract, produces supraspinal pain inhibition, and can also activate central inhibitory mechanisms influencing sympathetic efferent neurons. Data for neuromodulation for chronic low back pain. Again, these are all industry-sponsored studies, but the 10K Hertz simulation by Patel looked at 98% of patients, 98 patients with 82% of them experiencing a 50% decrease in chronic low back pain at 2 years. The Distinct study, another company, looked at almost 270 patients with 72% of patients reporting 50% decrease in chronic low back pain in 6 months. And then the DTM study looked at 112 patients, and again, 80% reporting at least 50% decrease in chronic low back pain at 2 years. So all very similar to one another. While the studies are showing promising results, and it shows SCS is superior versus conventional medical management for low back pain, the results are still early, and we need more long-term outcomes to get better data. So what are some new treatment options out there? These are things I've added to my practice over the last 6 months, 2 years or so. And medication-wise, suzetrigine, and then interventions, basivertebral nerve ablation and restorative neurostimulation. So suzetrigine is the first new type of pain medication that has been FDA approved in the last 20 years or so. I believe the previous one was Nucynta prior to that. And this was just approved in January of this year. It is non-opioid, so there's no interaction with the mu-opioid receptors, and there's no risk of addiction. So it is a NaV1.8 receptor, it blocks the NaV1.8 receptors in the peripheral nervous system, and that prevents the sodium ions from entering the neurons, disrupting the initiation and propagation of the action potential. Data based on the studies are looking at postoperative pain from bunionectomy and abdominoplasty. The reason they still use these studies or these surgical procedures was bunionectomy they attributed to treating bone pain, and abdominoplasty was for soft tissue pain. So this was published in Anesthesiology earlier this year as well. And this looked at, again, the suzetrigine for treatment of moderate to severe pain. So they had over 1,000 participants enrolled in the abdominoplasty and the bunionectomy trials. And patients were randomized to suzetrigine, placebo, or hydrocodone acetaminophen. There was statistical significance in improvement in pain scores versus the placebo for suzetrigine, but they were not able to reach any statistical significance versus the hydrocodone. It is something that our pharmacy is looking to stock, and something we're going to use in the inpatient setting. Dosing for this, it's a 100 milligram loading dose and then a 50 milligram tablet every 12 hours. We are limited to 14-day supplies of this. And again, in the data from the FDA, they don't tell us whether it's 14 days every month, 14 days every 3 months, or every year, what that 14 days looks like. But they are doing further studies to look at this for chronic pain as well. Safety of it, side effects were rash, pruritus, spasms, nausea, but this was no higher than the placebo group. And then it is also an inducer of the CYP3A enzymes, so it should be avoided with strong inhibitors such as itraconazole, and then also with moderate and strong inducers such as rifampin and efavirenz. Currently, they're looking at it for radiculopathy and also for treatment of chronic pain. The next procedure I added to my practice about 2 years ago was basivertebral nerve ablation. And the basivertebral nerve is found in the vertebral body, and it enters the vertebral body via the basivertebral foramen. It was found by Antonucci back in 1998 that it innervated the end plates of the vertebral body, and then by Frass in 2003 found substance P, which is how they knew it was related to pain. So just a good diagram. The basivertebral nerve is a branch of the sinovertebral nerve. Again, it enters the vertebral body via the basivertebral foramen. And the sinovertebral nerve is also a branch of the gray ramus communicans. So something we're looking for on MRI are something called modic changes. These were found by a radiologist out in Ohio at the time, Michael Modic. He discovered this, I believe, in the 1980s when he was reviewing MRIs and saw end plate changes. So there are three different types of modic changes. You have type 1, which will appear dark on T1 and bright on T2. And this represents fibrovascular changes, such as edema and inflammation. And this is more of an acute degenerative change. And these can be associated with pain, again, show high signal intensity on T2 and a low signal intensity on T1. Modic type 2 represents replacement of the bone with fatty yellow marrow. And this will show a bright signal intensity on both T1 and T2. And then type 3, which is not an indication for this procedure, represents replacement of bone with bony sclerosis with little residual marrow. And this will appear as low signal intensity on both T1 and T2. So where are we targeting for this procedure? We're about 1 centimeter anterior to the posterior wall of the, or posterior cortex of the vertebral body. And the electrodes heat up for to 85 degrees for either 7 or 15 minutes, resulting in a 1 centimeter spherical lesion. This creates a 6 millimeter sphere of neurolytic lesion within the vertebral body itself. How do we do this procedure? It's done under sedation. We do it in the operating room at our hospital. We enter the vertebral body by accessing the pedicle. Once we are in the vertebral body, we use what they call a J-wire to create the channel. We then place the radiofrequency probe, perform the ablation for either 7 or 15 minutes. And this can be done at L3 through S1. Looking at some data for this, the Intercept trial, this was a randomized controlled trial at 20 sites, looked at patients with either modic type 1 or type 2 changes at L3 through S1, and patients can receive up to 4 vertebral ablations. And outcomes were ODI at 3 months, followed up until 24 months. They compared this to standard of care, which included medications, PT, manipulation, acupuncture, injections. Results, the study was actually halted early after enrollment of 140 patients, with 104 patients analyzed due to superiority among the patients who received the BVN ablation. And just some of the data. So reduction in ODI was clearly significant versus the standard of care. And then also reduction in VAS scores was over almost 2.5 versus 1 for, or 2.5 greater for the ablation versus standard of care. They looked at this all the way till 24 months with allowing the patients to cross over, and you can see this was a continued significant reduction in their both VAS scores and ODI. The SMART trial was another industry-sponsored study, which was a randomized double-blind sham-controlled trial. And this was at 15 U.S. sites, 3 sites in Germany, and they looked at modic type 1 or 2 changes with a minimum of 2 levels, maximum of 3. At L3 to S1, patients underwent BVN ablation or sham. The sham procedure consisted of docking the introducer cannula 1 to 2 millimeters into the pedicle and simulating an RF ablation. But there was no RF ablation completed, and they looked at, again, ODI at 3 months, and then VAS and SF36. Patients, again, were allowed to cross over, this time at the 1-year mark. So 225 patients were enrolled, 147 to the treatment, 78 to the sham. There was actual statistical significant reduction in the patients who underwent the ablation versus the sham in VAS scores, as well as a decrease in ODI. 5-year results, again, significant reduction in ODI scores and also pains. At 12 months, 57 out of the 78 underwent the ablation who were in the sham group. So they did not have any statistical significance as it wasn't powered anymore, but 24 months continued to show sustained relief for these patients. Again, this is just a good graph that looks at the INTERCEPT, the SMART trial, as well as a prospective single-arm cohort study, and all the way till 5 years, these patients are getting sustained relief. This is not a procedure that we repeat in the office. These nerves should not regenerate. They're non-myelinated. So most patients in my practice are doing very well, and their pain is not returning. The newest procedure or surgical procedure I've added to my practice is restorative neurostimulation, and this is looking for multifidus dysfunction. And this is a restorative and not a palliative or an ablative therapy. We're implanting an IPG with 2 leads subcutaneously at the L2 dorsal ramus at each side. And then after implantation, the patients are using the device 30 minutes twice daily, and this is creating strong bilateral multifidus contraction via electrical impulses, and they should feel the contractions without any pain, and they do this twice a day in order to get pain relief. So just reviewing some basic anatomy, the multifidus muscle goes all throughout the entire spine. It's a primary stabilizer of the lumbar spine, and it's a sensor of proprioceptive input, which helps it maintain stability, and any type of dysfunction can be associated with low back pain. So MRI findings, we're looking for multifidus atrophy. On the left-hand side, we have no multifidus atrophy, a normal multifidus muscle. What we're looking at, slight atrophy, you can see in the middle picture, and then severe atrophy all the way to the right. Someone once explained this to me. On the left, you have a fillet, no fat, and then all the way on the right, you have the Wagyu, and that's not what you want to see in your back. You want limited atrophy. Physical exam findings, there's a multifidus lift test where the patient's lying prone and lifting their arm, and you're looking for contralateral multifidus firing. And if there's any delay in that or lack of firing, that would be a positive signal. And then the prone instability, where the patient, their upper half of the body is on an exam table and they're lifting up their legs, and they're experiencing pain when they do that. And if you're putting pressure on it, it should resolve the pain. Typically, I'm not doing that with my patients, as my patients aren't able to lift their legs if they're half on the table, so I'm sticking with the multifidus lift test. So how does restorative neurostimulation work? Again, they have the 30-minute sessions twice a day, and it's the mechanism proposed is a repeated multifidus activation is believed to reverse the inhibition that develops in chronic low back pain. Over weeks to months, the muscles are retrained, providing spinal stability and reducing the nociceptive input. Something I always warn the patients about: this is not a quick fix. You will not feel better next week. This can take up to 6 months, up to a year to feel benefit. The Reactivate-B study looked at 204 patients who were implanted with the Reactivate system. This was a sham-controlled, double-blinded, randomized study. And they had patients looking at activity, limiting moderate to severe refractory chronic low back pain with a positive prone instability test indicating impaired multifidus control with no indications for surgery. 5-year results, they noticed a mean ODI improved from 39 to 16, so a 22% reduction, which is significant. The EQ5D5L improved by 0.231, which is significant. And then 52 patients who are on opioids at baseline, almost 70% discontinued or decreased their intake. And out of the 74 patients who were not on opioids at baseline, only 2 started opioids at 5 years, which is really good. This shows improvement in ODI from 39 to the 16, and then also the improvement in the EQ5D5L. And this was all the way out till 5 years with continued improvement in VAS scores, about a 60 to 70% reduction. So what is next? The big thing I've luckily participated in and seen is focused ultrasound. We're using focused ultrasound for SI joint ablation, facet ablations, and so far the data is looking good. But I think that is going to be some of the next things we're going to see in chronic pain in our practice.